Meg Marmo. I'm an occupational therapist and work as the team leader at the Barbara Walker Centre for Pain Management at St Vincent's Hospital in Fitzroy. The Barbara Walker Centre is a full-time, multidisciplinary outpatient service providing comprehensive assessment and treatment for adults with chronic pain. The centre delivers individual and group pain management interventions to a patient population spread across Victoria and beyond. Service demand is constantly growing, with new referrals increasing by over 10% each year and a routine waiting list of approximately 18 months for an initial assessment. Efficient service delivery is vital to managing service demand, and face-to-face group programs have a good evidence base as successful chronic pain interventions. We currently offer telehealth consultations for rural and remote patients for individual consultations with moderate success to date. This has primarily been pain specialist appointments, likely influenced by the Medicare incentive scheme for telehealth, but also occasionally for psychology, physiotherapy or nursing care. The burden of travel to Melbourne is high for our patient population, and as with most outpatient services, there is a fairly rigid operating timetable which dictates patient appointment times. For patients with work, study or caring duties, not to mention the chronic pain issues and financial limitations, I'm hoping that ehealth service delivery may reduce the barriers for participation in chronic pain management interventions and provide another treatment option for these people. As the team leader, I am considering these three main variables. 1. Providing evidence-based care. 2. Ensuring that is patient-centred care. And 3. Maximising the activity of the service, which is funded by Viner Contacts. This basically means that the patient must experience either face-to-face, telephone, telehealth or email service to be counted towards an activity target point. So interactive eHealth solutions are more advantageous than standalone self-health programs. So my lit review is focusing on the top 5 papers on chronic pain group interventions. In terms of my search strategy, I used the Clinicians Health Channel database to search for full text articles that I could access both at home for study and in the workplace, and started with the keywords of chronic pain management and eHealth or informatics and interventions. 193 articles turned up in the search. I had to manually exclude many medication-related trials and was able to limit some of the search parameters by excluding paediatrics, cancer, palliative care and acute pain, as these were the predominant number of articles. I reviewed 11 full-text articles. 5 articles was to focus on papers which informed my purpose, that is, evaluating the potential for eHealth delivery of chronic pain management interventions. I sought high quality clinical trials and practical information that would inform the critical analysis of the potential to deliver existing Barbara Walker interventions via an eHealth mechanism. The papers I've included either offer evidence regarding the efficacy or lack of for a program, important patient-related learnings such as recruitment or retention issues, or practical learnings about service planning and service delivery factors. The first paper I've chosen is by Trudeau et al. And is an American RCT of an online self-management program. There's good evidence for face-to-face cognitive behavioural therapy-based group programs for chronic pain. This is a well-established intervention within chronic pain management, and at the Barbara Walker Centre we deliver an intensive face-to-face CBT-based program by multidisciplinary clinicians. So this program was of interest to me. In this study, they used an existing pain program called Pain Action that had had good results for different diagnostic groups such as back pain, migraine and neuropathic pain, and they developed an additional module for arthritic pain. There may be differences within efficacy of programs for different diagnostic groups just based on the pain profile of those people. Of interest in this program was the structure was similar to some of the group programs that we deliver, with sessions each week for a period of time and then follow up for 5 further months. And the researchers were able to monitor not only the time that the patients were using the program, but also the content which they used. They also were providing email prompts about participating in each weekly content, a bit like our program here does with our reminders weekly from Mark and Sue. And they also had a facility to prompt patients if they hadn't achieved the minimum time requirement for which they'd signed on for. Interestingly, the study managed to improve some areas of pain, particularly self-efficacy and pain catastrophizing. However, it didn't impact in confidence in ability to manage pain or awareness of responses to pain, which are some other variables. In the study, certain groups of arthritic patients performed better than others, which is of interest, and the overall conclusion was they were able to change cognitive factors, so the thinking about or understanding of pain, but not necessarily the follow-through of health behaviours. In our pain programs, we have to provide a high amount of care to achieve those change in health behaviours. It requires coaching, encouragement and trial and error and so forth, rather than just information at that level. So results are similar to face-to-face programs, but only particularly evident of statistically significant in the self-efficacy and pain catastrophizing domains. I found this paper particularly useful for my practice, as their cohort was not dissimilar from the Barbara Walker Centre and was looking at challenges related to introducing digital behavioural health interventions for chronic pain. So the authors identified some main barriers to delivering eHealth options and also made some practical suggestions about what to do about it. The authors recognised that many patients have difficulty accessing specialist pain management services, and that medication and surgery have limited efficacy for chronic pain, whereas self-management programs in the face-to-face context to date have demonstrated good results. So very similar to the Barbara Walker approach. The patient group was a low-income sample, primarily with low back pain and or arthritis. 50% had internet in the home, and the authors identified that many of those patients may not have been using the full capabilities of their smartphones despite having access to them. The patients tended to have multiple health conditions and limited access to skilled human resources to deliver chronic health interventions in their local communities. Again, this is very similar to the Barbara Walker Centre profile, and we know from our electronic persistent pain outcome collaborative results that compared to other pain services across Australia, the Barbara Walker Centre sees patients with a higher number of multiple health conditions than the average pain clinic. This article also identifies patient-based barriers for accessing care, such as things like access to childcare, financial limitations, and being able to get transport to tertiary services. The authors flag a risk to patient confidentiality with online-based programs, and recognise the unlikelihood of developing a one-size-fits-all model, which I concur strongly with. The areas that were main barriers were the health literacy, And the study identified that high eHealth literate patients have more frequent access to computers, use the internet more often, and search the internet for understanding and seeking optimal treatments. They do investigate and define different areas of literacy, health literacy and eHealth literacy, with the definition of eHealth literacy being the ability to seek, find, understand and appraise health information from electronic sources and apply knowledge gained to addressing or solving a health problem. That's a direct quote from page 209. A useful takeaway message was video and auditory commentary are effective for delivering to low literacy populations. However, these mediums require high-speed bandwidth, which is less likely to be available in rural and regional areas where there is a higher volume of these low literacy pain patients. So they make the point that without enough digital literacy to explore eHealth offerings, patients will not come to understand and appreciate the value that these technologies can have on their lives, and that eHealth will have to address the rapid advancement of technology by implementing research policy and practice that develops and tests meaningful eHealth interventions. I would hypothesise that in Australia we should see improvements with the introduction of better broadband services and growing access to computers and smart devices that may support people of all health literacy levels to access eHealth solutions. The authors also note that we should include an education component that promotes the role of technology as a valuable tool in healthcare, and they also recognise the need for clinical researchers to work with app developers to include eHealth literacy as a factor in the way programs and apps are designed. Overall, this was a very informative article and definitely one of the top 5 papers. This paper looked at ACT, or Acceptance Commitment Therapy, in an internet-based setting. Interestingly, the Barbara Walker Centre has just completed a trial of face-to-face group ACT plus physiotherapy group program. ACT is a branch of cognitive behavioural therapy, or CBT, which aims at patients increasing psychological flexibility to accept their situation and develop more realistic expectations regarding future pain relief. Multiple recent studies have demonstrated ACT can improve disability-related functioning of chronic pain patients. This study is very relevant to the rationale as it examines the opportunity to reduce delivery costs and attendance burden on patients, considering Barbara Walker have an ACT program that is currently face-to-face. However, the selection of patients in this study may not reflect the Barbara Walker patients, as these patients in the Dutch study were recruited via newspaper and online promotion, and they excluded severely distressed clients. However, based on our patient data, Barbara Walker clients are moderately distressed and show no difference from the national patient profile, so should probably be appropriate. Of note, half of the patients didn't adhere to the intervention as intended. In terms of outcomes, this program also improved catastrophizing, as did the CBT program reviewed in paper 1. Clinically relevant improvement was achieved, however not in all the domains, so covered several domains including pain interference, depression, pain intensity, psychological flexibility and pain catastrophizing. However, no change again in those behavioural areas of impacting engaged living and positive mental health. These results were at odds with other RCTs in the ACT area. Another curious outcome was that patients on the waiting list improved despite having no intervention. This was inconsistent with other studies and with general pain experiences. The results saw patients doing the program improve more than those in the placebo group. However, very strange that the waiting list control also improved without any interventions. The authors make a valid point that the questionnaire normative data is based on pen and paper data collection, and an interesting query for further research in understanding whether online collected data can be compared to traditional pen and paper data. This is particularly interesting for my service with the Electronic Persistent Pain Outcome Collaborative data collection. We're currently collecting a combination of both online and paper versions of the same tools, and will be an interesting query to examine further. This study also recognises that there's further research opportunities to look at patient characteristics for those who engage with online program completion versus those that drop out. This German RCT examines tailoring online content for specific patient groups and tests this with the type 2 diabetes and chronic low back pain group. My focus is on the pain results. In this study, the authors note that the good results have been seen in lifestyle improvement, which is comparable to the behaviour change that other papers were so far unable to achieve for some aspects of chronic health conditions such as smoking, alcohol, diet and exercise. I'm focusing on the pain group, and when I review the program that has been delivered to the chronic low back pain group in this study, the group content is similar to a program that the Barbara Walker Centre delivers called our Pain Education Program, which is a face-to-face group. The program is less intensive than our cognitive behavioural therapy group. In this study, the arms of the study saw differences in delivery of the information provided, with the intervention group receiving content delivered in dialogue form and tailored to relevant patient characteristics. The control group had the same content but just presented in website form and no tailoring. The outcomes from this study. The study was unable to reach statistical significance due to the level of dropout. When further evaluation of the results is looked at, the dropout of the chronic low back pain group from the tailored arm, they were significantly younger than other groups, and successful participation, one of the variables was most patients had higher education levels. When the data was reviewed by available case analysis, some conclusions could be drawn. These are that tailored web-based intervention may be better suited to chronic low back patients than diabetic patients. However, again, the benefit to improve knowledge has been seen to improve knowledge, but not to achieve behavioural change. So on reflecting on this paper, web-based may be a good delivery model for education level programs, but not necessarily as effective for CBT programs. The authors also point out a potential risk to participants that there's possible negative effects on cognitive or emotional domains. However, there's little evidence for this. This last paper is a review of an Australian study that invited patients with osteoarthritis to join or to access a website, My Joint Pain, for a 12-month period. There's a group that had access to it and, of course, the control group who didn't, and they were assessed at baseline and again at 12 months. That website had some user-specific information and tailoring. Now, we saw in outcomes there was a significant dropout rate again, so a common theme featuring in web-based program delivery, and unfortunately they were unable to reach statistical significance with their results due to the numbers, but were able to identify some positive trends in the article. So the authors pointed to those that did actively engage with the program found improvements in the targeted areas, and of note that those health-directed activity, engagement in life, self-monitoring and insight, some of those fitting into that behavioural group that the other studies I've reviewed have had difficulty getting to that behavioural change level within a pain population. They've also found that the control group measured increased emotional distress at the 12-month follow-up, which I believe fits with the Barbara Walker experience of patients on our waiting list and not receiving any care do tend to deteriorate over the time that they wait, and our data collection tells us that. The learnings from this paper suggest that the tailored approach seems to work better, and that most areas improved over time, although not to a statistically significant level. They also raised the question of older consumers and whether their IT skills or preferences for service delivery and their access to information technology methodologies, so whether it's computers or tablets and things, may be different. And in the osteoarthritis population, it tends to be an older group. In terms of big picture, web-based self-management tools have had some success with specific patient groups, and that includes rheumatoid arthritis, fibromyalgia and juvenile idiopathic arthritis as reported in the paper. But when I think about applying this to my service at the Barbara Walker, the potential for web-based self-management tool, it's unlikely to be delivered by the Barbara Walker Centre as it doesn't fit with our funding model, but it might be something that we could recommend in conjunction with, or perhaps while people are waiting for care, it may be a useful tool to guide people to, should we get some more evidence in that area. So based on my readings and summary of these 5 papers, some of the key learnings for me. Online programs can or have the potential to achieve improved knowledge in pain management. However, the ability to also achieve behaviour change is yet to be conclusively determined. I've learnt that if patients engage adequately, they tend to have positive outcomes. Also, that tailoring and interactive content appear to be key to successful programs, and that there's a need for further investigation of the validity of online assessment tools when they're being compared to pen and paper generated normative data. So in thinking about a pain service, my advice if giving recommendations for services considering online group interventions for pain management, I would suggest that targeting pain education is a good way to start, as there's good evidence of success here, and there may not be as much benefit for CBT-based care. But possibly in the future, mixed modality could be an option of face-to-face and online content. I would suggest that where possible, tailoring to individual health conditions or areas of demand, and I would suggest that there is a role for decision support, and particularly digital decision support, in interpreting baseline data and interests to tailor programs. Also learn that patients need adequate bandwidth and eHealth literacy to successfully engage in online programs, and this may require early education to upskill and identify the value in online programs. In my service, we are currently considering resourcing patients with a limited accessible iPad to view online content so that they don't have access issues with having to pay for downloading. I would suggest that pain services vary their content delivery, such as using illustrations and annotations, using video and audio commentary to maximise engagement, and that takes into account those lower literacy users. And that services support patients with email prompts, personalised counselling and monitoring to improve engagement. So whenever building an online system, to have the capacity to see not just how long and who has been on, but also what areas of content they have been looking at. and that there's further work to be done engaging with the Electronic Persistent Pain Outcome Collaboration EPOC to further examine the validity of the online assessment tools and how that is going to work. There's a unique opportunity at the moment because data is being collected both electronically and in pen and paper, and there's a large data set that there may be a clear way of defining the validity of that data. And they're my key learnings. In my final slide, I'd just like to share some pearls of wisdom that I gathered from other articles that didn't quite make the top 5, and they include something that I hadn't considered was that fraudulent participation occurs in the online recruitment environment, particularly where there's financial incentive to be part of a study, and that came out in a number of other articles. That older adults seem to be a different group, and we need to consider their needs separately, where we've got younger users who have grown up with technology and have a high level of comfort with using devices and computers. Older adults may not have that eHealth skill, that eHealth literacy. Connectivity seems to be another strong theme, that where we're trying to support people who live a long way away from specialist services, they tend to also have poorer internet access, bandwidth and broadband access. So we're limited in what we can potentially do or have to take into consideration people's connectivity. And the other two main things that I really took from other articles that is reinforced from the 5 top articles also was that health literacy is vital in program success, so delivering at the right level, and also that the longer people participate and engage with the program, the better their outcomes, which we saw in the top 5 papers but was also reiterated in other papers too. Thanks very much for listening.